department.
I call Gregory Stafford.
Thank you very much, Madam Deputy Speaker, and I want to thank my fellow sponsors of this debate, the honourable members for Yeovil, Waveney Valley and Sunderland Central, who I don't believe is in his place. Oral health is fundamental to dignity, confidence, employability and overall health. The ability to see a dentist when needed should never be treated as a luxury within a universal healthcare system. Yet that is precisely what has happened. And the consequences of that are not abstract, they are real, painful and increasingly visible. Tooth decay remains the leading cause of hospital admissions for children aged 5 to 9, though clearly poor parenting holds a lot of blame for that. A growing number of people are turning to so-called DIY dentistry because they have no other option. And Madam Deputy Speaker, that alone should give this House pause for thought. We must also be clear about what is driving this. It is often said that this is simply a workforce problem, but that is only part of the truth. As the Policy Exchange report Pulling Teeth sets out, there are over 37,000 dentists in England, yet only around 10,500 full-time equivalent NHS dentists. That is not a shortage of dentists, it's the shortage of dentists willing to work under the NHS contract.
Will my honourable friend
I will, of course.
Does my honourable friend agree that the British Dental Association, who've supplied an excellent briefing to many honourable and right honourable members for this debate, are in no doubt at all that it is precisely that contract from 2006 that lies at the heart of this problem? And they state that what they really want from this debate is two things. One is a clear timetable from the government as to when they will start to renegotiate that contract, and the other is a firm deadline for the rollout of the system, a new system, in this Parliament. Those are the two things that we've been invited to press the Minister to deliver at the end of this debate.
Well, my right honourable friend is precisely accurate, and I think the two calls from the BDA are absolutely right, and is what this government should be working to, because as my right honourable friend has said, this is a contract that started in 2006 under the last Labour government. It was based on units of dental activity, and it's fundamentally misaligned with clinical reality. So, for example, it pays the same whether a dentist does 1 filling or 6. Essentially, it rewards volume, not complexity, and it actively discourages preventative care. Now, of course, we also had COVID, and we have to remember that before COVID, around 4 million adults already struggled to access dental care. That figure has now risen to nearly 14 million. Of course, COVID didn't create this crisis alone, but it did significantly accelerate and expose it, and we're still dealing with that aftermath. Now, this government came in promising action. Yet, nearly 2 years on, the gap between promise and reality is difficult to ignore. The rollout of additional appointments was delayed, and even where delivered, the British Dental Association has noted they amount to only around 2 extra urgent slots per dentist per month. That's not transformational, it's marginal adjustment. And at the same time, as has been mentioned, the long-promised NHS workforce plan remains unpublished. The ambition to expand access depends entirely on having enough clinicians willing and able to deliver NHS care. So without a credible workforce strategy, the objectives of reform remain difficult to assess, let alone achieve. And that pressure, as my honourable friend mentioned, is not evenly distributed. In parts of rural England, there are as few as 10 NHS dental practices per 100,000 people. These so-called dental deserts are not random, they are the predictable outcome of a system that fails to align funding with need.
Will my honourable friend give way?
I will.
Thank my honourable friend from giving way, and he mentions rural communities in the dental deserts that there are. I represent a constituency, Fylde, which is split between rural and coastal, and those coastal areas are experiencing those same dental deserts, and I agree with him that the dental contract is at the root cause of this, and what we want to see from the Minister is a commitment to review that.
Well, my honourable friend from Fylde hits the nail on the head, and like in so many cases in healthcare, rural constituencies and rural and coastal constituencies are often the ones that hit the hardest, and actually it's where the government should be spending, in my view, its efforts and its money in order to ensure that we do get the same level of service as you would get in a large urban population centre. And that brings me neatly onto my own constituency, where the consequences are very real. One family contacted me about their daughter who lives with a long-term eating disorder and developed a serious dental infection. Despite seeking help, they face delays, long waiting lists and limited access to specialist care, with treatment stretching close to a year. Another constituent raised the case of his wife, a head and neck cancer patient. Following chemotherapy, radiotherapy and surgery, she now faces severe and ongoing oral health complications. Yet access to appropriate NHS dental follow-up has been extremely limited, forcing reliance on expensive private care. And these are not isolated cases, Madam Deputy Speaker. They are emblematic of a system failing those who need it most. We must also recognise the financial and operational pressures facing dental practices themselves. Rising national insurance contributions, increased wage costs and high levels of missed appointments all add further strain. In some practices, missed appointments alone cost tens of thousands of pounds a year. And unfortunately, in Hazelmere, in my constituency, I have a fully equipped dental suite in the local hospital entirely unused despite clear local demand. That's not inefficiency, it's systematic failure. So, Madam Deputy Speaker, incremental change won't fix this. We need a credible workforce plan, genuine contract reform that rewards prevention, and a strategy for dental deserts that goes beyond short-term fixes. We need a system that aligns capacity with need, rather than relying on historical allocations drawn up nearly 2 decades ago. There are also more fundamental proposals on the table, including models that would extend coverage and give patients greater choice and control. Now, whether or not every element of that is agreed by this House, what is clear is that the status quo is failing too many people for us to simply continue as we are. So I ask the Minister, who I have a lot of respect for, although I'm not entirely sure it's mutually given, when will we fully see a fully funded and credible NHS dental workforce plan? How many additional dentists, hygienists and therapists are actually required to meet demand? And what is the government's plan to ensure that dental deserts do not become a permanent feature of our healthcare system? Because, Madam Deputy Speaker, unless we answer those questions honestly, the government is not reforming NHS dentistry, it's supervising its managed decline.